All right, good afternoon, everyone. Hopefully everybody can see my screen and can hear us clearly. If you can't, please do let us know, and we'll do what we can to get that taken care of. Again, friendly reminder, mute your lines if you haven't already, if you don't have anything to say right now. But I have in the room right now Dr. Robertson with me, who is working with Eau Claire County. He is a child and adolescent psychiatrist, primarily out of Mayo Clinic, and works part-time with Eau Claire County as well in their outpatient clinic. Today, he is here to answer our questions around psychopharmacology. So you won't really see, I've got a title page up, but you won't really see me scrolling through anything. As far as the PowerPoint is concerned, this is a time for all of you to log in and to ask whatever questions you might have around psychopharmacology. So maybe you've got a participant or a consumer that has concerns or questions, or you just are encountering things that you've never seen before. Now is the time to answer those, get those questions answered. So, Dr. Robertson, I'll turn the time over to you.
Hi. Yes, as Adam said, my name is Dr. Timothy Robertson. I'm a child and adolescent psychiatrist. Worked at Mayo for many years, and before that in other settings. And I'm currently a supplemental physician. I'm semi-retired. And I work here in Eau Claire at the outpatient mental health clinic 2 days a week. And I had given a presentation on psychopharmacology maybe 2 months ago and thought this was a similar kind of a thing and that most people will have heard me before. So I was planning to do more of a question and answer thing, which I think will still work out okay. My work as a psychiatrist has reinforced for me the biopsychosocial model very strongly, and that meds are only part of what goes on. With CCS, the beauty of that is the team and the number of resources that can be brought to bear. And medication helps, but is only part of the picture. But within that part of the picture, what I want to do today is allow a chance for anybody to ask any questions they have about medication rather than my just talking about a specific topic, because I don't know what you're interested in. And I will be glad to answer any question, general or specific, excuse me, about psychopharmacology.
So right now, everyone, just know that I do not have the lines muted. If your individual line is muted, feel free to unmute and go ahead and ask any questions you might have. It sounds like we're not hearing any questions right now. Do you maybe want to give a little introduction to the topic, and maybe that will spur some conversation?
Sure. Such a broad area. That's why knowing what people are wanting to know is so helpful. Mm-hmm. I can talk a little bit about my work with kids. Most of my work is with kids and adolescents, and psychopharmacology in kids is not without controversy because many people have concerns about using medication in children and that sort of thing, and is it overdone, or does it hurt children's brains, that sort of thing. And the kinds of things we try to treat with children are severe ADHD, very significant anxiety, depression, bipolar spectrum conditions, psychosis, that sort of thing. First question here is thoughts on prescribing methadone and benzodiazepine simultaneously. My understanding of that is that it's contraindicated because of the respiratory suppression of using an opioid and a benzodiazepine together. That's a number of the high-profile deaths that have been in the news in the past few years have related to the dosing of those two together. The state has guidelines on, within certain dosing parameters, and so theoretically, if somebody needs both and it's being done in a very monitored way, maybe, but it's something that in general is not recommended.
So just so all of you know, I noticed that a couple of people had typed up some questions in chat, which is fine. I did not get an obvious notification that there were people typing via chat. So feel free to type in questions in chat. We'll get to them as we get to them. Or if there's a natural break, you're welcome to pipe in on your phone or computer and ask a question that way too.
And then this question is thoughts on naltrexone for children. And naltrexone is a drug that is used in alcohol withdrawal, in treating alcohol dependency and in treating opioid dependency. And it helps to reduce the impact on the dopamine opioid receptors in the pleasure center of the brain, the nucleus accumbens. And naltrexone can be used, like for a teenager who would have alcohol dependence or opioid dependence, it could be used in a traditional manner there. Where I've used it more has been in other addictions. So like in several teenagers with pedophilia and very excessive sexual drive who were, for example, masturbating to the point of rawness and not liking that themselves. Naltrexone was helpful in reducing their drive to a more normal drive. That's an off-label use for it, and if they have Medicaid, you have to submit a prior authorization and show evidence why you think that might work and what other things have been tried. But in conditions where there is an excessive drive for pleasure that is interfering in life, whether that's sexual or other substances, naltrexone is something that can sometimes be helpful and can be well tolerated.
Anybody else have any questions? Thanks to those of you that have sent questions in so far.
I have a question. This is Amanda from Eau Claire.
Hello.
I have a lot of kids who are prescribed Abilify, and I'm wondering if you can just talk a little bit about how that works.
Yes. So Abilify is in the class of antipsychotic medications, and there you have three generations. You have the original generation, Haldol, Thorazine, those kinds of medicines. Second generation, Risperdal, olanzapine, Seroquel, many others. And Abilify is considered a third generation, just in terms of its development and the pharmacology of how it works. Those, that group of medicines can be helpful specifically in treating schizophrenia. They can be helpful in treating the manic side of bipolar disorder. They can be helpful in reducing the irritability of associated with autism, the anger explosiveness associated with autism, and it can be helpful in oppositional defiant disorder children with that diagnosis who are extremely explosive and who haven't responded to other medicines like stimulants or guanfacine or an antidepressant, that sort of thing. Sometimes you work your way up to using those medications where there's extreme anger and explosiveness. It works by impacting the dopamine and serotonin systems in the brain in slightly different ways than stimulants do. It's like the opposite of what a stimulant does, and a little bit differently than what the selective serotonin reuptake inhibitors do. But it can be a very helpful medicine. One of the advantages of it over some of the others is it doesn't increase prolactin, which can be a problem with Risperdal, for example. But it is a medicine that needs to be monitored. There can be metabolic side effects, elevated blood sugar, elevated lipids, a risk of developing diabetes or metabolic syndrome, and there's a risk of weight gain associated with it. So it needs close monitoring. Did that answer your question?
It does. Thank you.
Okay. And anybody, if I answer a question and you have more, I didn't address it, please feel free to come back in with a follow-up.
Looks like we have another question in chat. How common would it be for a person on Abilify to have SS of TD?
It's uncommon, but not impossible. So tardive dyskinesia, which is it's a hypersensitivity syndrome. When you use an antipsychotic medication for a period of time, and that can be variable, months or years, usually years, the dopamine system is blocked to a certain degree, and over time you can get a hypersensitivity of dopamine receptors leading to the abnormal movements of tardive dyskinesia that you see in the tongue, the mouth, shoulders, arms, legs, trunk, that sort of thing, the abnormal movements of that. Abilify, because it both it has a variable response to dopamine receptors, is supposed to be one of the lower risk agents for tardive dyskinesia. The lowest risk one is clozapine, but Abilify is very low in terms of risk, but it can happen. So it's something that is watched for. And if they develop that, then that needs to be addressed right away.
Julie, did that answer your question? I know you can't use your desk phone as a speaker, but did that answer your question?
Oh, great.
Perfect. Anyone else have any questions?
These are good questions. The reason I wanted to do a question and answer one is that as social workers, care facilitators, you have a lot of direct interactions with adult patients, kids, people on medicine, and see very specific things and wonder about very specific things. So that's why I wanted to do a question and answer ones. That's interesting. CBD oil is everywhere. They sell it. There's almost no place you can go in Eau Claire that doesn't sell it. And like so many things that hit the market in that way, there is not research supporting the effectiveness of it on all the conditions that it says it will treat. That doesn't mean it wouldn't be helpful for certain things, but it just means it hasn't been tested. There's one form of CBD that is FDA approved for 2 rare seizure disorders in children. I think it's called Epidiolex, and it uses pharmaceutical grade CBD, but at the level that it's helpful for seizures, it's not without side effects. You have to monitor liver functions. There can be a fair amount of nausea, headache, things like that. Currently, with CBD oil and how it's being used, you have people saying this helped me or didn't help me, but that is just people saying stuff. It isn't double-blind, placebo-controlled trials. There are some trials going on. There's one, for example, I think out of Israel going on with CBD with another component of, I don't know which other component, but looking at that in autism. But until there's good data on specific dosing and double-blind, placebo-controlled trials, you're not going to know. The other thing you don't know is when people are selling CBD oil, there could be nothing in the bottle. There might be CBD oil, there might not be. You have no idea, no way of knowing what's really in there because there's no regulation, no licensing, no nothing. You just are taking your chances with that. You're welcome.
Anyone else have any questions? I think I can safely say there's always no such thing as a dumb question. I think there's no such thing as a silly question either. I think this is a time to get if you've got a curiosity or if you've got a specific case or anything like that, now's a good time to get that question answered. Have you heard about the new treatment for TD from Neurocrine? Hopefully I'm pronouncing that right.
Yeah, I'm not sure what the Neurocrine part is. Yes, there is a new medicine out for tardive dyskinesia. I've had no personal experience with it. It is FDA approved, and if I had a person at this point develop tardive dyskinesia, I would be looking into that. But from what I have read, it should be a potentially helpful medication. One of the things with medication, one of the hard things, thoughts on ECT. ECT is underutilized. It's very, very effective. It's effective for a number of different things. It's used in depression especially. There's other conditions that it can be helpful in. For depression, for example, it is one of those things that's feared because primarily of one flew over the cuckoo's nest. That's just wrecked it forever. But it can be an immensely helpful treatment. A lot of work has gone into how to reduce side effects. There could be some temporary memory effects, and there have been some recent studies looking at unilateral ECT and doing it twice a week rather than 3 times a week, for example, to reduce that side effect. But it can be a very, very, very helpful treatment. It can be used in adolescents as well. I've never seen that done, but it is one of the approved treatments for severe depression. TMS can also be helpful if it takes more time. It's a harder one to access and requires many, many visits. One of the things in my practice is the limitation of medicine by itself to make huge differences. Sometimes it can, like, if there's very prominent ADHD which has never been addressed and you effectively treat that, medicine alone can sometimes be enough. But in so many of the, like if you're in CCS and you're working with clients in CCS, usually much more is needed than medication. Cognitive behavioral therapy, dialectical behavioral therapy, the other supports that are available, mentors for kids, the family therapy piece. Those things are all extremely important, and when those things are in place, then there's a better chance that medication will help. There is research that shows that the more complexity, the more diagnoses a person has, the more trauma a person has, the more complexity of the social situation that's negative for them, the less effective medicine is. And in my own experience with CCS patients, once I can use medicine and make some improvement, but often with the kids with high need, it's not until a range of other services are in place that they're actually doing well and making the gains that you like to see them make. Ketamine is one of those things that's being looked at, and S-ketamine, that's like E-S-K-E-T, S-ketamine, which is a partial product, is a partial piece of ketamine, an isomer. There's good research showing that it's helpful. It's been around for a while, the research showing that it can be helpful. And the S-ketamine, because ketamine has to be given IV, it's limited its usefulness. S-ketamine is a nasal spray, and that is starting to be used more. But one of the things that's puzzling about ketamine or S-ketamine is long-term effects. Will it be helpful over the long term? How often does it have to be administered? And there was an interesting study that used naltrexone. Naltrexone was, you talked about earlier, as something for treating opioid dependency. And when ketamine and naltrexone were co-prescribed, when they were given at the same time as part of the study, ketamine did not work for depression, which meant that in some way the opioid system is involved in ketamine's effectiveness. And one of the concerns is that, okay, so if you're using this long term, are you creating a new group of people who will have an opioid dependency? And that question hasn't been worked out. There's some thought that the opioid effects are really not the same as addiction type effects, but that study was pretty dramatic for ketamine not working when combined with naltrexone, which blocked the opioid impact of ketamine. Ketamine, has psychoactive properties and has been a drug of abuse, and so that's one of these kind of how do you safely use it to get the benefits of it. So that's ketamine.
Effectiveness of clean diet versus medications.
That is one of those things that you'd have to do a double-blind placebo-controlled trial on, which is very hard to do. People define clean in many different ways. Over the course of my time in psychiatry, I'm not aware of any specific diet that makes a diagnosis-specific effect. So a heart healthy diet, Mediterranean diet, or the Mayo diet, or diets that are in general healthy, and the right amount of calories, not too many, not too few, and regular physical activity, exercise. Those things will be helpful. Can diet or exercise or those sorts of things mean you don't need medicine? That depends on the person. Usually, like if you have a severe major depression, you're not going to treat that with a diet alone, more than likely, or schizophrenia, or autism, or conditions like that. ADHD, with severe ADHD, generally going to need medication to reduce those symptoms. But things like anxiety, depression, for example, regular aerobic activity can be very helpful. I think that a high junk food diet probably isn't helpful, and you won't feel very good on it. And then you have the negative cardiovascular effects and often negative weight effects, which if you're reducing physical activity, that can be negative. But I don't know of any evidence that a clean diet per se will be as effective as medication.
Can you expand on that a little bit? I'm kind of curious what the diet versus exercise, the diet and exercise versus medications, like where's the threshold? Is it just kind of a trial and error? Because I'm thinking of cases where the anxiety or depression might be situational, or maybe it's more of a dysthymia type situation. Is there a good way of kind of feeling that out?
That can be hard. Like what diet does is helps you feel better by eating in a healthy manner. Your body is you're going to function better when you're eating healthier. But you still can have, people can have GI problems, other things, and can still not feel perfect, no matter how healthy that they're eating. There isn't evidence suggesting that any particular disorder is from diet, like depression, anxiety, schizophrenia, bipolar disorder, autism, things like that. What exercise does, aerobic activity, is it releases a lot of the same neurotransmitters that are impacted by psychiatric medication. And that might be especially true with anxiety, somewhat with depression, but its impact is short-lived, 24 hours. You're going to feel better 48 hours, for example. But so it's something you have to do regularly, but it is quite helpful. But then, like, let's say a person, is trying that and they're, they're still anxious. If they're wanting to stay away from medicine, you'd want to be, engaging in like cognitive behavioral therapy, for example, which has a good research base. And if you are, eating in a healthy way and you're exercising regularly and you're doing CBT and you're still depressed or still very anxious, then it's very reasonable to consider medication.
And if anybody's having any trouble with the chat or with phone or anything like that, and you're not getting, you have a question and it's not getting through, or we haven't answered it yet, don't hesitate to send me an email. I do have my phone on me, and I'm trying to be responsive to, concerns and emails as they come in. So.
With psychiatric medication, what you're doing is you're impacting neurotransmitter function in the brain, and cells communicate chemically with each other in the synapse, the little space between the cells. And when a neurotransmitter, serotonin, for example, or norepinephrine, crosses from one neuron to the next in a specific part of the brain, that triggers a communication, and a whole series of chemical things go on in that cell then. It's called second messenger system. Then there's like 4 or 5 or 6 different things that happen, and eventually you get a activation of messenger RNA and a protein produced that then goes to the surface of the cell and impacts the functioning of that cell. What we don't know is how does that translate into depression, anxiety, hallucinations, that kind of stuff. That's, the brain is so complex and we don't have answers to those kinds of things. But empirically, it's known that by impacting these neurotransmitters, a large number of people have had benefit in reducing depression, reducing anxiety, but certainly not everyone. No medicine is 100%. The response rate is often in the 50% rate for a lot of the medicines. Stimulant medicine has like an 80% response rate, 70-80%, which is one of the higher ones. But the brain is also deeply impacted by environment, by trauma, by other life events. So medicine certainly isn't a standalone thing, and it's always, except in rare, less common situations where it's court ordered, for example, it's very much a personal choice. Do I want to try this, not try this? And a person trying medicine isn't committing to a lifetime of medicine. They're saying, I'd like to try to see if this helps me, and if it's causing side effects, I'm not going to stay on it. So my interest in psychopharmacology developed early in my career. So when I was in my child fellowship, which was back in 1983 to 1985, medicine just was not used much in kids. There were very few choices, and stimulants were used just kind of for short term, for example, for ADHD, but there really wasn't much else that was being used. There was some looking into other things, and I saw kids in the clinic that I worked in that were very ADHD, very depressed, very anxious, very aggressive, and was learning to do therapy and that sort of thing. And therapy alone for a lot of the kids simply wasn't enough. And I then worked with supervisors and that who had an interest in psychopharm to learn more about that, because it wasn't part of the training programs back then. And then it gradually became much more the case. And nowadays it's emphasized in psychiatry too much because of the way insurances have gone. So you're just doing rapid med checks and this and that, which is really not a good thing for clients. But my practice has been devoted to kids with more prominent conditions, multiple conditions, more seriously ill. And a lot of times, if we couldn't help turn down the volume on the difficult behaviors, the difficult moods with medicine, the child continued to struggle or would need some kind of hospitalization or some kind of residential placement or something. They needed some out-of-community placement because of how severely disturbed they were. So it often came down to, could you find a medicine that would help within the context of all of these other supports? But that's where my interest in psychopharmacology came from, is in trying to help kids with really severe disorders where the non-medication interventions alone weren't helpful enough.
Off topic, but why is there such a shortage of psychiatrists out there?
That's a good question. It's a very reasonable question, and there are a number of reasons. It isn't fully understood, but like when I was in medical school, psychiatry was looked down on just terribly. It was like you just weren't even a real doctor if you went into psychiatry. It was really frowned upon to go into psychiatry. And that isn't the case anymore, but it's still not seen as a valued profession. So like being an orthopod or orthopedist or being a cardiologist or a cardiovascular surgeon, that's seen in a much more favorable light than being a psychiatrist, child psychiatrist, that sort of thing. The reimbursement for additional training and that sort of thing isn't the same as other specialties. Psychiatry isn't alone in that. Like infectious disease has a shortage of specialists because they're not paid commensurately for what they do, for example. But there's other fields that for the same amount of work and effort you can make more money. So part of it is a money thing, part of it is a status thing, and then part of it is how the field has changed so that just doing med checks all day long for many physicians is mind-deadening work. You go into psychiatry to be connected with people, and a lot of the systems that have evolved, for financial reasons primarily, have pushed psychiatrists into the 10-minute, 15-minute medication prescribing, and that is really hard because you're just it's like throwing darts at a dartboard without knowing the person, the situation, having a relationship. It's very hard to prescribe well, and there is not insurance reimbursement for prescribing well. The other thing is there's many more headaches in trying to do what you want to do. So like 10 years ago, the Mental Health Parity Act was passed by Congress after decades of trying to get parity, meaning that insurance companies would pay equally for similar work in psychiatry versus in medicine or surgery. And that was passed, but then it wasn't enforced. And the American Psychiatric Association has spent the last 5-10 years carefully documenting that it isn't being enforced, and that through carve-outs, through excessive prior authorization that doesn't exist in other aspects of other parts of medicine, it's been very hard to get care for people that they need. And so there now is a bill before Congress moving through that is the Mental Health Parity Enforcement Act. So this is like 30 years in the making of trying to get fair reimbursement for treating mental health patients. And then because you don't generate income when you're in a big hospital system, which most medicine has gone to hospital systems nowadays, corporate medicine, you're automatically not someone that administrators want to have around because you lose money for them because insurance doesn't reimburse properly. So that's part of the reason why there are shortages of psychiatrists. And then the child psychiatrist shortage, which is more severe than adult psychiatry shortage, has to do with all of that, plus the additional training you take on to be a child psychiatrist without getting reimbursed for that when you're in practice, and the many more hassles that are involved with treating kids. You're dealing with schools and families and social workers and all these other things that when you just have an adult in your office you don't have to deal with. So psychiatry in general is not one of the preferred areas for resident or for medical students to match into when they finish medical school. It is sad. So it makes sense, but sad is what Julie wrote. And part of the reason that I came, when I retired, that I came back to work part-time is because it is a shortage area, and I still very much like what I do, but needed to find a little bit better balance at my age. So It is sad. It is a very much of a need area.
Along those lines, is there anything to be said about the transition? I don't know if I want to call it a transition to or from anything, but the creation of the PMHMP and moving some of that responsibility to nurse practitioners. Is there anything to be said on that?
Oh, absolutely. Nurse practitioners can do a marvelous job, and you know, the need for additional providers where, you know, there aren't enough psychiatrists, absolutely. One of the challenges is getting enough training to, as a nurse practitioner, to see the, you know, very ill patients, and the stuff you learn in medical school, residency, child fellowship, all that is very relevant, and with a shortened amount of training, you're going to have less of that, and then that can be impactful in the day-to-day care of patients. So you want, ideally, you like situations where there's easy access to consultation around difficult cases and stuff.
Please discuss Buspar as a PRN. Seems to me like using, sorry, I have to scroll. Prozac PRN, just not going to work, but yet I run into docs prescribing it that way.
Yeah, Buspar is not supposed to be used as an as needed. It takes a while to work, just like Prozac takes a while to work. You don't use SSRIs as needed, and it isn't recommended that Buspar is used as needed because it doesn't work that fast. It's something that has to have some time to work. One of the exceptions of an as-needed kind of thing would be an SSRI like Prozac or Zoloft for premenstrual dysphoric disorder, where you're using it right at the beginning of symptoms, like a week before menstruation, because the immediate serotonin impact seems to make a difference there, whereas in anxiety and depression, you need a longer period of time, you know, 2 weeks, 4 weeks, for benefits to occur, and that's the same with Buspar. So I'm not sure why it's being prescribed as needed. Everything I've read and learned over time is that it is not an as-needed anti-anxiety medication.
Just as a time check, everyone, we are at about quarter till the hour. So if you have a question, you know, please feel free to send it our way. Even if we're talking, feel free to put something in chat, and we'll just get to it as we get to it. But just so everyone knows, just you know, we have about 10 or 15 minutes left here before the end of the hour.
One of the things on the use of medication in kids, I have many teenagers that I see who are adamantly opposed to taking medication, and but they have some significant suffering that medication could help with. And much of the time, maybe even the vast majority of the time, when their concerns are listened to, discussed, and they are able to see that they're in control of whether they're on or not on a medicine, they end up wanting to try something because they're having enough emotional discomfort from their sadness, anxiety, anger, mood swings, whatever. So it's interesting to me how often a teenager will be interested in trying something when they feel that they have some say in it and when their worries and concerns about a medicine are discussed. So I've always found that kind of interesting.
So I think perhaps since you know we're seeing kind of a slowdown in questions, and it is 10 till the hour. Unless somebody has one final question to ask, I think in deference to Dr. Robertson's time, I think we'll go ahead and close for today. Thank you all for your questions. There were some really good ones in there, a lot of them really good ones. And thank you, Dr. Robertson, for your time.
My pleasure. Thank you for the questions. Julie, I think you asked the most of them, so thank you.
Well, if I'm not mistaken, and Julie, correct me if I'm wrong, I think there's a group of people upstairs in a room together.
Oh, she was the typist.
I think she was just typing them in. But
all right.
But thank you to all of you for joining. Just like the other ones, my intention is to get this posted on YouTube for review here in the next couple weeks. And thank you all for joining, and have a great day.